The Institute for the Study of Peak States presents the 5th International Psychoimmunology and Psychobiology Research Symposium. In this video, a panel discussion on priorities and physical clinics, rolling treatments out into the world.
Okay, so welcome back everyone. So this is the last session for today, a panel discussion. So we've got all of our speakers from today and from yesterday here joining us. So we've got our basic research team with our founder, Dr. Grant McFedridge, our director of research, Dr. Kirsten Lukkegaard, and our medical director, Dr. Mary Pallissier, and then our 6 applied researchers. Most or 5 of them are actually here, and they're actually all together in Denmark at the moment, just given their presentation sharing. So the theme of this particular discussion, or one of the themes, would be around, so you now heard about some case studies of some of this stuff and phase 1, phase 2 clinical trials. So we're getting very close to actually releasing this. So we're planning on having physical clinics. So how's that all going to work? So that's one of the key things we thought might be of interest now, but we're also happy to take questions around any of the discussions we've had, given we've got all of the presenters here at the moment. While people are thinking about what questions they want to ask, there were a couple in relation to the last talk from the applied researchers sharing their experience. So given one of the things that you shared was, obviously it can be challenging and you feel broken at times, and so there's obviously risks and potential downsides. There's clearly an intrinsic motivation you have. You want to make a difference to the world, but what are some of the other benefits? So you briefly shared around sometimes you get some peak states. So I think to entice some of the others to consider this as a future career, that they might be interested in hearing any interesting stories you have around what have been the most kind of interesting states that you've experienced as a result of doing research testing. Anyone got any stories?
Me, I remember, no, it's not a state. It's more like, if when we do a process, then I felt this intense joy from it. It was about the copies, and you talk about that, Kirsten, I think, in your talk, about some people were having a great impact and not having copies anymore. So it was more like revealing what was already there, kind of. So increasing what was there. So more in this sense for me.
Feeling in the flow. And then I had the added benefit of Lyme and TBI. That was fantastic.
Yeah, what's nice about it is that we don't know how good we can feel. And
yeah, exactly.
And sometimes you finish a process, it works, and you're like, wow, what is this? And sometimes it's a little bit scary, but then you get used to it, hopefully, and you realize, wow, this is how we are supposed to feel.
And then it's normal, and you forget. It's just my blood, kind of, But that's why pictures feel like amazing, maybe when you get it, but then it's like, yeah, okay, it's like breathing, you don't really notice it.
Yeah, at first it's wow, yeah. But then you get used to it.
Exactly. Yeah. So,
but so far we're just working on it. We'll hear about it later, I guess.
Yep. So Evan was asking, are you just working on the psychoimmunology level with the research testing you've been doing? Or are you also working on the psychobiology level as well?
So it's only the psychoimmunology. So all the processes that have been talked about in the symposium, that's what we do.
Yeah.
And we have done all the other things earlier.
Oh yeah, and some of us have been in research for a long time before, so there's been a lot of other psychobiology research. So, different years are working on different topics, I guess.
But you can also say when you're stuck in a process, what hell can I do? I can't get through whatever it is right now. So in the end, we always go back to basic and ending up with wholehearted healing and tapping and reversing. And, we are back to basic. Also without the basic, we can't do this.
Because we have such a strong model with foundation. So something that is going wrong, we go back to the model and the biology where it's going wrong, and it's logical in the sense, and you can always find something.
Yes, that's why we need all the training, because we need to understand what's happening and what is not happening correctly. So we always use psychobiology as a background model.
Yeah. I would say, Kirsten, Grant, Mary, what's happening? Because they know more, of course. So yeah.
I guess kind of
One
elaborating
of the
on
things
that.
I
Go, Mary.
just want to pop in here, Shane, and then you can go. Is one of the things I try to tell them. Sometimes they'll like, oh, I can't do this, or this isn't working. They come up with a problem, and I'm like, oh, that is so cool. We didn't know that could be a problem. So they get stuck and things happen. And I'm always so thankful, because it's like, okay, now we know that that's a problem, or we didn't know that was going to be a problem, or we hadn't considered that, or what's going on. And it forces the three of us to go back and go, oh shit, now what? Why is that happening? So I'm very thankful for them just to being so present and sharing what's going on. And I'm thankful that they have problems, so that later down the line, when we're into the phase 2 testing and into clients, that they don't have to have those problems. That it's like, okay, hopefully the buck stops here, and they're picking up all the things that we don't want other people to have.
We should call ourselves the problem guys.
Yeah.
I'm sure Kirsten and Grant would do a much better job of explaining this. So while what Gaetan said is the research testing the applied research team's been doing over the last 9 months has just been to help us do the safety and efficacy testing of psychoimmunology treatment, so that we can get that released out to the public. We need to understand the psychobiology behind all of that. So we always want to understand kind of more than what it is that we actually release in the world. So each of the psychoimmunology treatments, we actually do understand the psychobiology that actually surrounds that. And we will look at measurements around that, but it's actually not needed for the psychoimmunology treatment. Is there anything else, Kirsten, Grant, you want to say around that? Am I learning something about research and sharing that?
Sorry, we were on mute. I think you explained that well there. So if you imagine that the treatment is in this narrow slot, we want to know the landscape that's where that is based on, so that if any client in the future is a bit wobbly in their healing, or whatever might come up from what's around this event, so that we actually have preempting, or so basically what the applied researchers are saying, that if they're doing the testing, things might come up around that, and we find out more about it. But in our basic research, that's what we do. We really question, and our model says that we need to do this, and that makes the landscape much more, we know that landscape, not to start with, but that's what the process is, to get to know it, so that we have every piece in place. And sometimes it's like, we think this could go wrong in theory because of this, but then we look for it and maybe we don't find it, but it's part of our background understanding that we do.
Yeah, sometimes like we were surprised. Oh, it went well. So yeah, we love that. Yeah.
I think just one other thing I want to stress here is that we're working, people have used the word model, but we're working from a model of what is reality like, if you will, that explains all the phenomenon we encounter in the world. And fortunately, we have just a master model builder who carries it all in his head, but we're always testing reality about that model and trying to refine it and build it. And sometimes it's like, wait a second, this does not fit in the model. It's like, nope, that's not working. And so then we really have to go digging and go, as Kirsten would say, what don't we know? What don't we know that we don't know? And trying to find those things. And when she's talking about kind of the landscape around a process that we have, that's what we're trying to figure out. How far can we go out of knowing the things that we don't know and investigating that?
Quickly, I like, because sometimes we ask Grant what's the endpoint or something, he don't say anything. He wants us to experience that, not be influenced, and really have an honest answer with or have a real feedback from us. So this way, it's real.
Let's see how many of us find the blue banana.
Yeah, exactly. But in fact, it was pink.
Okay, Grant, we got to come up with a blue banana state.
Yeah. And where is the blue banana?
To add that with the model, like, I mean, we're not just trying to hammer it into the model. We have a model, and then we actually test, is that model holding up? If it's not holding up, we go, okay, there's something here that we haven't understood quite. And then we go investigate. And sometimes it turns out that, yes, the model was true, and that
And it was
for
just
some-
the slackers
and
who
for
didn't.
some reason- and that has really, I mean, pulled us through a lot of moments there. But sometimes we and then we figure out that what we had needs to be modified.
Kirsten, can you
Actually-
say the last part one more time? You're chopping up.
It looks like she's frozen again.
We too many.
Turning off.
Was working well.
So
How's that? Any better?
Yes,
No,
try
it's
again.
it's on-
So everyone in the Denmark
so I don't know how
household
much
should
of
have
it
their.
you didn't hear.
Yeah, we missed pretty much the last 2 or 3 minutes.
We've
I
turned
think.
our phone.
Can we turn it on?
I think we've
Oh,
got
can
you
we
now.
go to our own
Yeah.
Wi-Fi? Do you hear us now?
Yeah, I think it's good now.
Okay,
Okay.
cool.
So what I was saying is that we don't just try to fit things into the model. If data that the crew here comes up with, or our own data, does not fit in, we don't bang on it to get it into the to the little model here. We actually look at, so this understanding that we had with this new data set or this new observation, how do they actually fit together now? And then we create the model, go onward from that, and encompassing that new observation, and then we verify with that that's actually the new understanding is fitting.
When we're talking about model, we're talking about psychobiology model, and so heavily biology and relevant. The other thing is, in everything we do, we start with a model, because how the hell are you going to know if it agrees with the model? Phew. And if it disagrees with the model now, is it due to those 6 slackers, or is it due to the fact that we made a mistake? But it's really model driven.
Again, a mistake in the assumption of something, right?
Or they just did the process wrong, or there's a glitch in the procedure, and something like that. Yeah, model driven.
And so what is probably the most, I see this over and over, that if we don't have this, that the understanding that we have fits everything, we don't like taking a process out, because there are just too many unknowns in that field then.
Well, that's true. We
We
have to feel like we really
we-
have nailed this thing completely before we're willing to expand it to real clients.
Okay, so the theme was around.
Um,
Oh, sorry. Yep. You had something else? Grant?
Julian is talking, but
Oh, you're on
He's
mute
on
there
mute.
in Denmark. Yep. Sorry.
Sorry, I was saying, yeah, so what you are saying is also because you want to know all the landslide before, because if something happened, how does it explain with the model? So that's why you need something very understood.
And honestly, it's the engineering approach. And as a recovering electrical engineer, I prefer that. That was a joke, folks who don't know what I mean.
And you don't just prefer it.
I'm an
I think
electrical engineer through and through. Yeah. Better, faster, cheaper is tattooed on my shoulder. You know, that's the engineer slogan.
So our theme for this panel discussion was around, the physical clinics. What's the plan there? So, Mary, as our medical director, what are some of the, this is I guess a new field that we're moving into around. We've done lots of work around helping people with psychological disorders, and we're now moving into using this model to now help us have treatments for medical diseases. What are some of the things from a medical perspective that we need to consider that has us believe that we're probably going to need physical clinics to get this out into the world?
Well, what we're doing is disruptive. What we're doing is very disruptive to how conventional medicine is generally understood and practiced. So the first thing that we're doing is disruptive because we have an electrical engineer running the model. And in electrical engineering, if you think about how the electricity works in your house and you flip on a light or something, you want that to work pretty damn near 100% of the time. That's not how things are in medicine. Well, let's give this to you and see if we can make things a little bit better. But what we're going for is the traumatic brain injury symptoms are gone. The Lyme disease symptoms are gone. The Parkinson's disease symptoms are gone. You do not have that condition anymore. And that really is not understood in medicine. That doesn't make any sense for most doctors, especially when we're talking, I mean, we have this whole field of things we call chronic diseases, because the best we're hoping for is to ameliorate the symptoms, make them better, kind of decrease your suffering as you have this disease that we don't know how to get rid of. So that's a big problem in moving into medicine, is it just doesn't compute, for example, in doctors' brains. And I think that's probably one of the reasons that, first of all, people listening to us be going, you guys are just, I don't know what you're smoking, but this does not, I mean, it just doesn't make any sense. And I don't know if Kirsten remembers, but when we were at the TBI conference, people just looked at, I mean, they didn't know what box to put us in. They just didn't know how to even comprehend that. So I think for that reason, having physical clinics where we're working in person, when we have the ability to connect with other clinicians, to connect with our clients, not so virtually as like we're doing here. I mean, this is so super cool, right? Because I'm old enough to know before there were computers. So I'm just awed by what we're able to do, and that we're having this conversation, and you're in Australia and I'm in the middle of the night in the Pacific Northwest, and you guys are in Denmark. I mean, that just like freaking blows my mind. In any event, sorry about that. So I think that's why we want to have physical clinics. And it also, many of the questions that have come through, and I answered some of them, but people were asking things like, well, have you tried traumatic brain injury for birth defects or cerebral palsy, or in TBI from chemical problems, or what about, stroke or paralysis? And I'm like, yeah, what about those things? I don't know. We just came up with this earlier this year. So we're very, very early in the process. I'm very excited that you're very excited, you know, to ask those questions. But those are all the things going on in my brain. But we can't do this alone. At this point where we are, we need to connect with other clinicians who are willing to help us with some of this research to connect what we're doing, our model, our psychobiology model. So we're sort of doing, in some ways, theoretical psychobiology. And the huge loop that we need to close, did I say that right, Grant? I closing loops. I want to close the loops, is connect what we're seeing in our processes with what clinicians are seeing on brain scans or under the microscope and such. And it's one of the reasons why Lyme's disease is exciting, because we're always talking about all kinds of parasites. But if we start to talk with a doc and we start to talk about the Borg fungus or the manipulation fungus, they're like, what the F are you talking about? I mean, that does not compute. There's no, I don't know what species that is. Now, we think there actually is something that we can find, but we don't know what that is. But with Lyme disease, we think we are targeting that specific bacteria that's been identified. So that's really cool to be able to close that specific loop around the pathogens. But we have all kinds of connections to do with other clinicians and experimenters to see what are the limits. What do we know that we don't know about these things? And I have no idea if I answered your question, but there you go.
I enjoyed hearing your perspective, Vera. That was awesome. Thank you. So, Kirsten, for you, given your background in pharmaceutical research and having the experience of getting drugs out into the world to help people, what can we learn from that field that's going to be important for us to get these kind of treatments out into the world of psychoimmunology treatments?
Well, the difference is just so big, I think, that it's, I don't know if you can draw a parallel or even, I mean, because when you go through the drug development phases, you go and get your approval at FDA or EMA, and then you collaborate, I guess, with doctors who need this drug for their patients. Or it's
Well, then maybe explain why it's going to be so different to that, because that's kind of the only model people have got in their head at the moment, is how a drug gets released. Oops, we might have lost them again. They might be frozen again.
They are still talking.
You can hear them. So everyone else there in the room has got their phones on Wi-Fi off. Yep.
Did it work?
Yep.
Are we back?
That worked. We're back. Yep. That looks much better now. So we didn't hear anything that you said, Kirsten. So.
Oh,
Start from the beginning.
okay. So nothing. Okay. So I was saying that developing a drug, you end up throughout your development to get an approval at the medical agencies. And after that approval, it usually means that now the drug is available for doctors to prescribe, which is where you will meet your doctor in the office, and they say, oh, there's this new drug, which he has learned about through some kind of interactions with usually the company who promotes their own drug. But just also, if there is a need and this new drug is on the market, it will automatically roll out, because the doctors needs it. So in a sense, the whole system that the medical field is set up, as here in the Western world, is set up to actually receive all these new treatments. So, and we're not in that same category because we just demonstrated today that with our first trial on our processes on this psychohymnology on some chronic diseases like Lyme disease and chronic or traumatic brain injury, that we have a product, but that doesn't automatically roll out to doctors. So how do we do that? That's just going to be very different, and that's where the setting up of a clinic and starting out small and just doing our job is going to be our way of initially getting out on this in this field. However, it's going to roll out after that. Who knows? I think it's all possibilities are open for anything to happen there.
Mm-hmm.
And there's also personal motivation. For example, I wanted to do the Parkinson Project mostly because I admired Michael J. Fox, and I see how he's suffering, and I really wanted to get a cure for him so that he could use it. The problem, of course, is that you can't reach through the buffers to get to these people to say, hey, look, we have a way to fix it. But maybe someone out there listening will go, hey, Michael, guess what? There's some people doing some cool stuff.
So, grant@pigstate.com.
And that's in a similar sort of way. Type 1 diabetes has always been, we haven't got it ready for, we're not expecting that later this year, but certainly soon after that, we're hoping, fingers crossed. But one of the reasons why we want something like a type 1 diabetes is you're then going to have a simple medical test, which is going to make it a lot easier for us to kind of demonstrate to the conventional medical community that this stuff really is working. You can't argue with those independent laboratory tests. You can argue with our model, you can argue with our explanation, but you can't argue with those laboratory tests. So that'll be on our list of treatments. We've done some research on that. We will be aiming to do some more research on that in the future.
And I would just say to Evan asked a question there about getting the attention, and I think he said we need a miracle treatment. So type 1 diabetes has always been our, okay, they're not dying without their insulin anymore, and they now are producing insulin. I mean, that's what we're going for when we get that done, which we're not working on currently, but so we'll see. But
it's on my to-do list. I figured this fall.
Mm-hmm.
So.
Oh, hear that, Kirsten?
Yeah, that'll be good. Okay.
Get the yeah.
So any final words that anyone wants to share around getting physical clinics set up, getting these treatments out into the world, or anything we've covered in the first couple of days so far? No, we've all had that chance. Okay. Well, thanks everyone. Grant, you got one more thing you want to say?
I got one.
Yep.
We talked about this last night. I don't think we've talked about it on the air. In many people's thinking, there's a huge chasm between psychology and medicine. And it's been interesting in the staff who also have this kind of this underlying belief, not rational belief, but just underlying feeling that the two are completely different areas. And it's going to be interesting because the therapists have this thing and the doctors have this thing. Mary, you ran up against this last year. Do you want to describe it?
Well, quintessentially, it's this thing we do in medicine. Psychiatrists, they're not really doctors.
Sorry, Thomas.
We never really say that. They have the MD or the DO degree, but I mean, it's bullshit. But that's kind of, and the classic, it's all in your head, that a doc might, if they are tactful enough not to say it out loud, they may be thinking it and like, this does not fit in my box of this is a physical disease. And yeah, that's rampant in the field, sometimes very explicitly, probably a lot more implicitly without being said outright. And I had that and probably still have it a little bit, I think. Grant's gonna, but we've worked on that a lot. It's trauma. It's a big trauma that, I mean, I don't know if it's in the whole human species or just in those of us trained in Western medicine or Western psychology, but yeah, it absolutely blocks our ability. It's a huge blind spot. Let me just call it that. It's a huge blind spot. And realizing the potential of what we're actually doing, which is, to be perfectly explicit, eliminating physical diseases with physical symptoms using healing of psychological or emotional trauma. And as I said, that's what's so disruptive about this, because that is just not a thing that's understood or accepted by most people. But I know personally, for me, being pounded over the head by someone who's near and dear to my heart, that it's possible to change that. And yeah, we haven't, I mean, we know some big places of what needs to be healed to change that. Probably a little bit more work to do in that, but it's possible to change that. Now we just have to bring it to scale in the rest of the world, right? Yeah.
That's a little bit similar to what Life was talking about before, that we're doing all this research around psychoimmunology, but there are some things where we face our own resistances. We just go back to our foundational trauma release techniques to, you know, we all got stuck beliefs. We all still get triggered at times, and yeah, they're important to get back to those trauma healing techniques for us to continue moving forward.
Absolutely. Yes, absolutely.
Yep. Okay, Grant, any final words you want to say before we sign off today?
Thank you everyone for listening, and the team for participating in this annual symposium. It really warms my heart to see everyone working on this and moving it out into the world. Yeah, we're all doing this because we see the suffering and we want to do something about it. Yeah. And as we have the capability, let's use it.
Mm-hmm. Okay. Well, thanks everyone. That's it for today. So tomorrow we've got another set of case studies around chronic fatigue syndrome. You're going to hear about the different psychological disorders we've been addressing with psychoimmunology. So we look forward to seeing you all tomorrow. Bye.
Bye. Bye.
For more information, please visit our website www.peakstates.com.